TopMedTalk.
Well, hello, and welcome to TopMedTalk Down Under. I'm Andy Cumpstey, and I'm here again with my co-host, Kate Leslie, at the Australian and New Zealand College of Anaesthetists and Faculty of Pain Medicine's annual scientific meeting in Brisbane, Australia. So we're both at the TopMedTalk booth in this busy healthcare industry exhibition hall, and we're right next to the stand of our generous sponsor, Southampton, which was formerly known as 3M Healthcare, and we're really looking forward to some more interesting and powerful conversations. Now, at the opening ceremony, alongside many inspirational quotes from Nelson Mandela, the co-conveners cleverly used lots of song lyrics from the likes of Coldplay, Eminem, and many others to introduce the official theme for this year's meeting, which is, of course, limitless. And many speakers have been continuing this theme to try and sneak song lyrics into every session since. So, never one's to be outdone here on TopMedTalk. I'm half a world away from home right now, but I'm still standing amongst all this science that I don't understand. And of course, there's also so many social events here at Limitless 24 that it's a kind of magic place. And finding my way around Brisbane this week and these last few days, I've been lost, I've been found, but I definitely don't feel down about it all, Kate. I've had the time of my life.
That's great, Andy. Now, with this TopMedTalk conversation, of course, we're doing it for the kids. But already I think you've said too much, so maybe before video kills the radio stars, perhaps it's time for a little less conversation and a little more action. And should we let our first guest introduce themselves?
How do we both do, Paul?
I mean, that was excellent, guys. So, my name's Paul Lee Archer, one of the co-conveners of this conference, and that was some excellent song lyrics there. I mean, to quote Marvin Gaye, what's going on?
What's going on?
Yeah, that's nice. Thank you very much for the opportunity to have a chat.
So if you just tell us a bit about your background, where you're working and what you do.
I'm a staff specialist anaesthetist at the Queensland Children's Hospital. And so I've worked there. Well, the hospital has just turned 10 this year, so we're having our 10th birthday celebrations. But as well as my clinical work, I'm interested in research. I did a PhD looking at behaviour change in children after general anaesthesia. And so now my research interests are sort of following on from that and looking more broadly at outcomes after anaesthesia in children, and particularly how we measure them and how we can do a better job of measuring those outcomes to improve patient care in the future.
And Susan, if you want to introduce yourself for us.
Hi, I'm Susan Humphries, and I do have an Irish accent because I trained in the UK, but I've been in Brisbane about 15 years, and I also work in the Queensland Children's Hospital. And my interest for the last probably 20 years has been how to improve oxygenation, because that is the most scary thing, to go pear-shaped in the night by yourself. And so my trials have been involving how can we make it better and safer for children as far as oxygenating them goes.
And I'm cuddling one of your many mascots, Susan. You're well known for this. It's so cool. This is Henry the hamster. Who else have you got in the zoo over at the Children's Hospital?
Well, we've got a buffalo, and the buffalo somehow is involved with our flexi bronchs with high flow oxygen, and we've also got a giraffe. Giraffe was involved with the gastroscopy high flow trials. My co-presenter here, who hasn't arrived yet, Britta, is responsible for finding all these soft toys. We've also got an acorn, which is involved in our consumer engagement studies, and the list goes on, but today I've only got 3.
I think it's a wonderful way to try and engage children and their families in medical research. How have you found it? Do you think it works?
Look, I do think it works, but I think even before we get to the children, I think having a mascot, even to present at a scary meeting like the CTN, sets the scene for this is how it is. And it's an icebreaker. It's a good way to collaborate with my other chief investigators in the other sites. If we all have the same hamster, it's like a talking point before we actually talk about the science that we're going to investigate. As for the children, they're very happy with whatever you give them as long as it's not a sharp needle.
My trial is the SNAP study, and we're looking at sugammadex and neostigmine, and different to you, we're handing out bottles of schnapps.
Our parents would have something to say about that.
You're probably thrilled.
And I have to ask this, has it always been animals, all the acronyms? Because in the UK, we've got a group of very active paediatric anaesthetists, but all their trial names are fruit. So,
well, they can stick.
peachy.
That's really boring. No. We've got animals here, and yeah.
hamster then. Should we start with that one?
Yeah, so the hamster trial has been discussed at length for the last 5 years, and I'll just tell you quickly, the name is just an embarrassment. It was made up locally here in Brisbane when we thought it was just going to be a single centre study, and we just quickly changed to give it a name. Then realised with other interstate, that this was going to become a multi-centre trial. Having the name hamster was a bit dubious, but it's been well accepted. And this trial was specifically for looking at children who are booked electively for microlaryngology. So they're the children who have got an abnormal airway for whatever reason. And we looked at the question of, with these children, if we give them high flow, do they do better during the procedure than with our traditional method of limiting the flow rate to 6 litres per minute? So we had 5 states involved with this, and over the course of about 18 months we enrolled 530 children. We were very specific about what we were doing, and so we had time frames during the anaesthetic which we only looked at incidents actually whenever the surgeon had the airway, because that's supposedly the time whenever the anaesthetist is most happy to hand it over. And we looked at 3 different oximetry traces to make sure we would know exactly when a desaturation occurred. So we looked to see, does high flow reduce the incidence of a rescue oxygenation during the surgical procedure?
And which children were you looking at that in?
So these were children aged between 0 and 16 years, presenting electively. So obviously then they were fasted and booked properly. If you couldn't breathe through your nose, for example, you had a choanal atresia, then you were excluded. If you had a tracheostomy, you were also excluded, but just about everybody else was included.
So you said you've talked about this for 5 years now, but you're nearly there with getting some results, we hope. So we can't talk about the results yet today, I know, but we're hoping to get those soon. Is that fair to say?
The results will be presented very soon. So we did well with our recruitment. That was finished maybe 2 years ago, and it takes an awful lot longer than you would expect for data auditing, processing, and then analysis. Then the exciting part is, well, we've got all this data and it looks clean. What does it mean? That's the exciting part.
And so we're just going to pause there for a second, because Britta's just very kindly joined us, having a fantastic prize session in the main hall. You've just rushed over to come and join us on TopMedTalk, so thank you very much. We're very grateful.
Thank you so much for having me. Sorry for being a bit late.
No, not at all, not a problem. If you could just tell our listeners your full name, a bit about your background, and then we'll pick up from there.
My name is Britta van Ungern, and I'm a consultant specialist at Paediatric Hospital and the Foundation Chair of Paediatric Anaesthesia at the University of Western Australia, as well as the Director of the Institute for Paediatric Perioperative Excellence at the University of Australia, and the Program Co-Lead for Perioperative Care at the Telford Kids Institute.
Fantastic. You've been very busy the last few days with presentations last night and more prize adjudicating just now, and very busy few days for all the paediatric anaesthetists at this conference. So it's great to get you all here on the couch together and joining TopMedTalk. So thank you for that.
Thanks for having us.
So we were just talking about hamster, and you've got a whole history of other animals, haven't you, in previous trials you've done? So you want to mention some of those?
Yes, so we've got a buffalo, and the buffalo was our mascot for our flexible bronchoscopy, use of high flow. And that involved, obviously, collaboration with the respiratory physicians. And we shared that study with Perth Children's Hospital as well. So we recruited 80 children, probably over about 12 months period, specifically looking at, again, can we keep them oxygenated better with high flow or not? Also running at the same time was another trial. We called that one the giraffe. And this time we looked at, is high flow a feasible option for oxygenation during gastroscopy? And the important thing is, if you only work in the adult world, you think, what on earth are you doing in paediatrics? But we cannot assume that just because it flies in the adult world that it will fly in children. So we've been very specific about how we make this new technique safe. So these have been feasibility studies, which will be probably ready for results in about 6 months.
Excellent. So again, slightly provocative and challenging question. I'm sorry about that, but it's slightly deliberate. But we've just been trying to do some work in Southampton looking at oxygenation in paediatrics. And we had difficulty getting ethics for that, because the ethics board said that anaesthetists don't give paediatric patients having anaesthetics lots of oxygen. So aside from that question, How have you managed to get so many excellent trials through in pretty quick succession? Are there any difficulties with ethics in children, and how do you get over that?
Well,
That's for the whole panel.
I think the first oxygenation trial we had here in Brisbane, I suspect the ethics committee didn't terribly understand very much about high flow, but it does help to have Paul in our local ethics committee. So are there questions coming up, he can jump in and answer them straight away and alleviate any fears that we're actually trying to cause damage, because we're not.
So I'm sorry.
On our ethics committee, I'm on our ethics committee as well as our chair of our ethics committee is actually an anaesthetist, Ed.
Yeah.
So he's an adult anaesthetist, but still really helps. I think the way how we counter most of the ethical issues is by we really think what are the risks, what are the safety concerns, and we put a lot of safety measures in for our patients. So we don't just go ahead and do the trials. We really actively think with them. We engage very closely with our consumers. We in Perth have a consumer reference panel of adults with either children who had anaesthesia or in the chronic pain spectrum, or also young adults with lived experience in the perioperative space. So we get their opinion on any trial before we started. We see if it's actually acceptable to this panel of consumers. We have consumer youth ambassadors, so youth between the age of 10 and 16, who we also engage in what's their opinion. Do you think this is actually an acceptable trial? And we get very intense questions, particularly from our youth consumers. They tend to be even more critical than our adult consumers. So we really take lots of safety measures to ensure that this is working well. And also all our trials have consumer buddies, which sort of follow the trials on the side as well.
So by following the trial on the side, are they actively involved with running the trial or feeding back?
So they feed it back. So we introduced it slightly after hamster, but we're running other RCTs at the moment, be pain-free, for example, looking at honey tonsillectomy or gabapentin for tonsillectomy in the GAP trial, or the CHIMP trial. We love animals.
Yeah.
With clonidine for tonsillectomy.
Tell that the paediatric zoo, isn't it? And it was fantastic.
We do. So in Perth, we've got a whole zoo of animals sitting there, and we've got our partner zoo up in Queensland, and we're very passionate about our zoo. We really have the buddies who work very closely with us in already the trial design now. Some of our studies actually co-designed with the consumers. Really, how do we do it? Because a lot of our follow-up in our pain trials is at home. So we have to get buy-in from the parents, how to do it, how to do the diaries, etc., etc. And then the buddies are the ones who we catch up with them every 6 to 8 weeks about the trial, if there are any issues, if there are any problems with recruitment. They help us actually with the spiel. So the team of the recruiters will actually talk to the buddies and say, is that a good spiel? Do you actually understand it? Before we actually go to the first family and go to them and talk to them. So it's not just information material beforehand, which goes to ethics, which is pre-checked from the consumers, but actually the spiel, how people interact.
Excellent. And Paul, you sit on the ethics panel as well and have recently finished your PhD, I believe?
Yes.
Yeah, so congratulations on that as well.
Just picking up on the point with the ethics, there are some added complexities with ethics for children because obviously it's the parents who are actually providing the written consent.
Exactly.
But having said that, we very much try to make sure that the children are empowered and have a voice. And so if we're providing information about the study, it has to be targeted at them in age-appropriate language. And so leaflets that are very colourful and that they can understand. And so we sort of empower where possible, protect where necessary. That's kind of, I suppose, the overarching ethical principles. But as Susan alluded to, we can't just sort of take adult studies and say, well, we've got evidence for children. It's really important that we actually do the work to provide the best possible evidence in kids. And I think that's increasingly recognised now that we need to do that.
So I think take-home message is we've shown we really clearly can do these studies and we need to be doing these studies. And that shouldn't be a barrier that we let people put up and stop us doing them. And I believe, so you've got a society that helps with this sort of research, is that right?
Well, we've got a Society of Paediatric Anaesthesia in New Zealand, but I think the main thing is we're a very close-knit group of people. We're only 5 paediatric hospitals.
The people outside Australia, where are those paediatric hospitals?
No, I mean that within nationwide. So we talk with very closely. It's because we're so few, we meet up, we talk, and that's how we plan trials. Outside, it depends. Different people have different connections. My team, we work very closely with Boston. We work very closely with Philadelphia, Wake Forest, BC Children's, Toronto, a lot of the European centres around Italy, Switzerland, France. So we've got a really big network. But in paediatrics, because again, we are actually, if you look at the world, fewer centres than the adult land. And our populations are so much smaller. So to run bigger trials and actually get the answers, we really have to work together, all of us. So we have a really good network around the globe where we just sort of interact with everyone, like, look, I'm running this trial, would you like to come on board? And then the different centres see if they can actually get on board for that particular trial or not.
And does that change the methodology of those trials as well? Because, I mean, with hamster, for example, 0 to 16 years, that's a really wide age group, and the physiology changes a lot in that time, doesn't it? But also the reading age, reading ability, the role of the parents in the children's lives at different extremes in that spectrum. How do you manage that with this sort of work?
Well, it really depends what we are studying. So in hamster, we were studying a novel technique, which we wanted to see over all the patients where we're using it. We're looking at the moment, we're doing a large international observational study where we're looking at popsicle, we're looking at the development of chronic pain in children after common procedures. And that we have lots of substrata depending on the age, because we're looking at anxiety and coping and resilience. And that is measured very differently in young infants and children as it is in teenagers. So we just see what do we actually assess and then see which age group we are going for.
Yeah, and if I could just pick up on those international collaborations, because I think it is important in paediatrics because we are a small community, and we do have good working relationships with other countries and other centres, which enables us to do high quality research. And so in some of the work that I've been doing on looking at measuring quality of recovery after surgery, there was a group in Philadelphia and Boston who were also interested in that, and so we combined our resources and use different methodologies to sort of help one another, I suppose, to develop a score that has been now tested and validated. So those connections that Britta mentioned, I think are very important in our particular specialty.
So finally, Paul, you're one of the co-conveners of the meeting along with Dr. Sarah Bowman. You must be very proud and relieved about how the meeting is going so far.
Oh, definitely. It's all come together really well, and the regional organising committee, I think, have been fantastic to work with over the last 2 years, and the events team at ANZCA as well, who really do all the heavy lifting, and we come along for the ride. But no, it's really great to actually, you sort of start out planning these things and it's hard to really imagine it actually happening, and now that we're here and off and running, it's just nice to be able to kind of enjoy the whole meeting.
And then Queensland is hogging the ASM. We're having it next year in Cairns, in far north Queensland. Can you tell us a bit about that on behalf of the next crew?
Well, I'd certainly encourage everyone to get up to Cairns, particularly if you haven't been up there before. It's a really beautiful part of Australia. The launch this morning, they mentioned how you have got the Daintree rainforest and the Great Barrier Reef. So it's a really fantastic place to visit. And also I think the meeting's going to be great. Really good organising committee up there. They've already locked in some great speakers. And, even though it is Queensland again, it's worth remembering that it's further to get to Cairns than it is to get to Melbourne from here. So it may as well be in a different state.
Thanks, Paul. And thanks to our wonderful guests today. It's been wonderful having you on TopMedTalk.
Thank you.
Thank you.
Thank you.
TopMedTalk. Thanks for downloading TopMedTalk. Don't forget to subscribe. Check us out on YouTube. And of course on social media. We're on Instagram, Facebook and X. Also, it's important to remember that TopMedTalk is the broadcasting arm of EBPOM, evidence-based perioperative medicine. We'd love you to find out more about that, and the way to do that is ebpom.org. Check out our website and find out about some of the incredible conferences we're going to be arranging across the year. ebpom.org.